We'll go through definition, clinical features, epidemiology, pathology, look at how we can use imaging to get some of these CSF leaks, and we look at essential differentials. So there's this 32-year-old female who in February 27 presented to the hospital with constant headaches and a history of right-sided pulsatile tinnitus. A CT scan image was taken of the patient, and they said it was neo-acute. So we see the sagittal CT scan of the brain. This is the maximum intensity projection, emphasizing the vessels. But I want to draw your attention to the fact that despite the lack of clarity on the parenchyma, we see that there's definite effacement of the posterior fossa systems. Notice the peripontine system, the basal system, and the perimedullary systems are all effaced, including the superior cerebellar systems, despite this saying that there's nothing of acute. Patient continued to have symptoms, and about a year and a half later, she presented with 3 weeks history of visual loss, more on the left side than the right side. However, this time the headaches had subsided and she had no nausea or other neurological deficits. This is a T1 weighted image of the patient, and there's evidence of tonsillectopia with sagging of the brainstem, as we can see here, and effacement of the peripontine system. Likewise, there's enlargement of the pituitary gland with the draping of the optic chiasm over it. This brings us to our topic for discussion this evening, where we look at intracranial hypotension, which goes by so many other names, such as low intracranial pressure syndrome, low pressure headache, CSF hypovolemia syndrome. And this is when the CSF pressure is less than 6 centimeters, and the patient has a positive clinical presentation of intracranial hypotension. It's primary when it is spontaneous. Secondary, when we have other, we can ascribe causes to it, such as previous procedures or surgeries, or there's overshunting done by placed devices, or there's a history of trauma. According to the International Classification of Headache Disorders, you have diagnosis of a spontaneous intracranial hypotension attributed to low cerebral fluid pressure, and this is the absence of any procedure or trauma attributable to the cause of the CSF leakage. And if you have headache that has developed in the interval as a result of the low occurrence of the low CSF pressure. An important note is that if the person has headache and cannot be diagnosed if the person has undergone a dural puncture within a month. So if he had a procedure done within the month, then the person cannot be said to is having a spontaneous intracranial hypotension. It means he has a secondary cause. And dural puncture to measure CSF is deemed not necessary if you have positive MRI signs to show leakage of CSF, which is showing dural enhancement with contrast. We'll go over the features later. So if a patient has signs of hypotension, and you do an MRI imaging and it shows positive features, then you do not need to do a lateral decipitous lumbar puncture to measure the CSF of this patient. It's good to bear in mind that if a patient does not have a low hypotension of the CSF, it does not rule out spontaneous intracranial hypertension. In chronic patients, they tend to have compensatory mechanisms such that they don't have a typical presentations and their pressures may be normal or may be increased in the case of obesity obese patients. And patients that have these high pressures will tend to bleed for longer periods. The incidence is about 5 per 100,000 people per year. However, you should know that this figure is underestimated because most of us fail to pick up this condition in our reporting. And so there are a lot of people who keep skipping from one doctor to the other, and their diagnosis is being missed, and so do not add up to the number. People in the 4th to 6th decade are mostly affected, with a predilection for women in the ratio of 2:1. If you have a secondary cause, then that will affect the epidemiology of the intracranial hypotension. How do these patients present? Typically, you want to have pressure headaches or positional headaches. When the patient stands up, then he has severe headaches. Upon lying down for about 15 to 30 minutes, these headaches are relieved. May also present with nausea, vomiting, may have vertigo, nerve thickness, can have eye symptoms or hearing symptoms. If there are secondary causes, you can have clear rhinorrhea or otorrhea. Worst case scenario is increased level of consciousness and coma. So let's look at this Morrow-Kelly doctrine, which says that you have an equilibrium involving the brain tissues, the CSF, and the blood. So if there's any loss of volume of any of these 3 components, then the other 2 components must necessarily expand to keep the equilibrium intact. So in the case of SIH, where the CSF is being reduced, definitely the brain tissue cannot expand or be added on. So it's the blood vessels that tend to distend, and out of the arteries and the veins, it's going to be the veins that can cause distension. So in SIH, you have to look for venous distension. That's a compensatory mechanism to keep equilibrium. Results of SIH is from CSF leak along the spine. If it's trauma, then you can have intracranial fractures or lesions causing it. So causes include dural dehiscent tears from osteophyte complexes. If you have focal absence of dura or the nude nerve roots, or there's CSF fistula to the venous plexus. In other cases, there will be small sphenoid meningocele. There are other connective tissue diseases that predispose patients to having CSF leaks. These include the Marfan's Ehlers-Danlos syndrome and the adult dominant polycystic kidney diseases. We have to remember that CSF leaks can also be iatrogenic. Leak is where you have the spare or degenerative changes of the intervertebral discs causing a tear in the ventral dura. Now we have CSF leaking, and the CSF can then go a long way and travel along the ventral epidural space of the patient. This is evidence on this digital subtraction myelogram, where we see the leakage of contrast at this level. So this is the CT myelogram, and at this level, depicted by the blue line, you have a distal osteophyte complex with spares of the posterior osteophytes. At this level, we can see the osteophytes here on this axial CT image. And in this image to our right, you will see that there's a double contrast sign in which there's a hyperdense contrast within the dural sac, and the less dense extravasated contrast in the extradural space in this patient. A type 2, the tear is more at the neural foramen or the sublateral lateral recess, such that you have some of the CSF still coming into the dural space. But with these leaks, it means that you need to have positional changes in order to elicit the leakage. So with this patient, he was placed in the decubitus position, and there was leakage of contrast through the sleeve at the thoracic segment. So this was digitally subtracted, and this is a non-subtracted digital subtraction myelogram with the features of SIH evidence on the other pictures. We will talk about them. Type 3 occurs where there is no leakage of the CSF into the ventral space. However, there's a direct or fistulous communication between the sleeve and the adjacent venous plexus, such that you see that there's contrast leaking and extending along the venous plexus, as we can see in some of these DSM, which is the digital subtracted images. So you have linear extravasation, which tend to extend along the areas of the veins. So with the type 3, you don't see any free extravasated CSF in the epidural space, and these ones are quite difficult to catch on imaging. So this is a CT with a dual energy, and it shows myelogram with contrast around the cord and extension into the adjacent vein here in this image. And on the dual image, it shows us better the now iodine stained vessel in that on the left side. So this is also goes to show that there was a diverticulum at that level, and we see extension of contrast along the lateral venous plexus. A type 4 tear will be extradural, so along the sleeve, such that there is a tear which allows the CSF to seep out, and there is no CSF leakage into the epidural space. So if you are doing any imaging, you are just waiting to see CSF within the epidural space here, it means that you're going to miss it, because all the CSF with the contrast is going to leak outside. So such patients, you need to do a decubitus. The patient has to lie on the side, and you may have to be repeating the procedures just to pick them. If they are intermittent, then you are not going to get them that easily. So we see again a DSM which shows the leakage through a type 4 tear of the dura. So what are some of the radiographic features that these patients will present with? That said, it's important for us to get this concept so that we do not miss the patients that we report on. So by virtue of the loss of CSF, there's going to be downward displacement of the brain through the incisura. This is due to the lack of the buoyant force that the CSF was going to exert on the brain stem. And this downward displacement of the brain or brain sagging also causes other features that we will see, because it will also further compress the adjacent veins, cause more distensions. It may cause the draping, the chiasm over the enlarged, and may cause the depression of the corpus callosum, the spinal part, into the vein of Galen and the cerebral veins. An important feature is diffuse dural enhancement. And remember that we said that if there are MRI images of dural enhancement, positive dural enhancement, together with the clinical features, then we do not need to do a CSF pressure measurements by a lump puncture. As we said by the Morrow-Kelly principle, our dural veins are going to be distended. So you look out for these veins. They may cause along the dura will be thickened, and these ones will have to be smooth because you just want the thickened and the pachymeningeal enhancement. So veins will be distended, and this could be either intracranial or along the spine. Another concept is the subdural fluid collections, and this is due to the fact that the sagging of the brain causes distension of the subarachnoid spaces. And so there may be tears along with the small veins in these dural spaces, causing collections within the subdural space. And this may be either hygromas or hematoma. It's possible to find features of in SA. However, it may appear normal. You may find subdural collections there. If you look closely, you may see effacement of the systems around the suprasellar region, the basilar system, or the pons. And the pons will appear to be patterned. And post-contrast image is possible to see the dural thickening and enhancement, as well as signs of distension. So this is an image of a patient with SIH, and we see here there are something subdural collections along the frontal convexities bilaterally. And this sagittal image, the suprasellar systems, as well as the basal systems, and the prepontine system is also partly effaced. However, MRI is a modality. On T1, you'll be able to appreciate sagging of the brainstem, which we've talked about, due to the lack of buoyance force on the midbrain, and it causes optic chiasm and the hypothalamus to be draped over the sella. Venous dural sinuses will be distended, and we will look out for convexity of the dural venous. The pituitary gland will be enlarged, and there will be caudal displacements of the tonsils, to which we have to rule out HYRI1 malformation as our essential differential. On T2 images, realize that you are able to pick up a thickened dura, which will show as hyperintense on T2. Subdural fluids too will be there on T2 and flare. And the nerve sheets around the CSF around the nerve sheets will be decreased. If there's any hemorrhage, then you will have blooming on the susceptibility with the images. There again, we expect to find dural enhancement, which is thin and smooth with no nodularity associated. But however, we've said that it's not in all patients. In patients who have chronic symptoms, they may not show these signs. However, it's good to know that in about up to 90% of patients who fall under the categorization of the ICD will have abnormal brain MRI features. Brain imaging is important in SIH, okay? And every patient that we suspect that is having an SIH has to be imaged, where an MRI brain has to be obtained. However, the findings, when present, are very helpful in correlating with the patient's symptoms. Be careful and note that its absence will not rule out your diagnosis of SIH. So don't put in your report that there are no features suggestive of SI, and it's, if you don't see any feature, the reports that it cannot be excluded and further needs to be done. So this MRI diagram is showing some of the features that we have to look out for on MRI. It's going to be venous distension, and instead of having a concave outline of the venous, is going to be convex. Okay, the expression of the splenium of the corpus callosum, which is gives us the venous hinge sign, and narrows angle between the internal cerebral veins and sagging prominent or enlarged gland, right? There's also slight sense of the tonsils that will also be seen. So let's look at more of these 5 features. So this is the digital FLAIR image, and it's showing the effacement of the prepontine cistern with tonsillar atopia on the image that we see here. You realize that it's like the mammapontine has a distance here between the and the so we look at this T2 axial image and realize that there's a hypotenuse collection and the frontoparietal convexity bilaterally with no significant mass effect, and due to subdural collection that we talked about. We have to see smooth thickening dural enhancement in our MRI. Because if you have regular enhancement of the dural, then you have to entertain other differentials of inflammatory or infectious or neoplastic causes. And you have to bear in mind that you are not supposed to see any leptomeningeal enhancement. So pachymeningeal is the dura should enhance, and not the enhancement of the leptomeninges. Okay, so here on this sagittal image, we can see the venous distension as evidenced by this convex curvature of the veins here. All right, so this image, we see that there's hyperemia of the enlarged pituitary gland, and this pituitary gland may extend beyond the confines of the cella, okay? And that's all features of the SIH. Venous engorgement is a significant thing in SIH. So you can see the postclival enhancements in patients, and it's all due to dural enhancement and the engorgement of the veins in that region. So we see avid enhancement within this region. Bear in mind, you can also see enlargement within the venous plexus on the spine images. So extension, we see here, I keep saying, the convexity of the dural sinus in an engorged, and in the post-treated patients, it returns to normal, where you have like a more of a concave sinus. For the hyperemia of the pituitary gland, you want to make sure that there is convection of the upper mass, as well as increased vascularity within the pituitary gland. Okay. Sagging of the brain, a major component of the SIH. So in the coronal images, for a normal patient, you draw a line, the dural line, okay? You realize that we see that this is the red nucleus and the midbrain here. They all sit above the incissural line, and you have the pons and the medulla below. But in cases of the brain sagging, you have dural shows the red nucleus and bulging or lateral bulging of the midbrain below this line. Okay. In addition, you look at the normal appearance of the infundibulum and the optic chiasm, upward slanting, right? But in SIH, over the pituitary gland, there's loss of the buoyancy.
Dr. Jackson, Dr. Jackson, you are the host. I think you can mute everybody. You are so you mute everybody. You are the host. Or please, everybody, put your mics on mute. Everybody, thank you. I think you may continue.
Okay. Okay, so I think everybody's muted now. All right. So with the SIH, we see that there's downslope of the infundibulum and the hypothalamus over the pituitary gland. So it's important to take note of these other features that we are talking about. So you may not find all these qualitative signs on every patient. So it's important to take note of these quantitative measurements that can be done. You can look at the mammaropontine distance, the pontomesencephalic angle, the interpeduncular angle, and the venous hinge sign. So in the normal patients, you want to have quite a distance between the mammillary body and the pons. In SIH, this angle will be reduced less than 5 millimeters, okay, 5.5 millimeters. The angle between the midbrain and the superior surface of the pons, if it's less than 50 degrees, then you should know that there's some sagging of the brainstem. Likewise, you can do the measurements between the interpeduncular system here, and if it's less than 50, then you know that you are dealing with some form of brain sagging. The venous hinge sign has specificity of 92 and a sensitivity of 88%. And this occurs with the dragging or depression of the splenum of the of the corpus callosum, indenting into the cerebral veins, internal cerebral veins, and the vein of Galen, narrowing the angle to less than 79 degrees. Okay, so this is indicative of an SIH, something to look out for. Rare, but it does occur, is the presence of hemosiderosis or staining of blood along the brain parenchyma in superficial siderosis. And a study shows that about 50% of patients that had superficial siderosis had some CSF leaks also. So when we see images of patients with superficial siderosis, we should also think about the possibility of they having CSF leaks, adding to the symptoms that they are presenting with. And this is thought to be either like the margins of the torn dura bleeding and causing this hemosiderosis layering on the brain. So how do we approach the imaging for such a patient? There are varying strategies that people use. But the aim is to identify where CSF is leaking from. Most of all, you want to first of all, have an MRI of the brain with contrast. And we said that if you have pleural enhancement, then you do not even need to even measure the CSF to suggest that there's, or to confirm that there's low pressure within the CSF. We want to do a speculative epidural patch post to the MRI of the brain, following which an MRI of the spine or myelography can be done. In cases where there's a fast high volume leak, you want to consider digital subtraction myelogram or a dynamic CT myelogram. If you have a positive MRI of the brain and a positive MRI of the spine, then you want to consider putting the patient in the prone position whilst you investigate for the leak. However, if your MRI is positive and your spine imaging is negative, then you have to place the patient in the lateral decubitus position, because it's either the patient has a type 3 or a type 4 kind of CSF leak. If you are having no leak at all, or it's thought to be intermittent, then MRI myelogram will be important with intrathecal injection, as well as considering nuclear medicine studies. So with MRI of the brain, you want to confirm the diagnosis as well as exclude other essential pathologies. You want to rule out any lesions that may be confounding the symptoms of these patients. It's essential to do a fast saturated T2 weighted images, because this helps to limit the false localizing signs that can be seen on the T2 weighted images. An epidural blood patch is speculative, it's non-targeted. For some, they just do it at the lumbar spine, and others too prefer to do it at the 3 levels in the cervical, thoracic, and the lumbar region. The success rate could be as good as 95%, but you may need to do a repeat of these epidural blood patches. It could be within like a week or 2 after the first one has been done. If you have an epidural fibrin glue, if you want to do that, then it means that you are certain of the exact location where the leakage is. Then you can apply the fibrin glue at that level. Otherwise, we just do an epidural blood patch. So here, the venous blood of the patient is obtained and it's injected into the epidural space of the patient. So if it's successful, then the patient's symptoms are going to improve. So this is a CT guided image where we use the needle, we get to the epidural space, we confirm that we are not in the thecal sac. Then we'll go on to do the placement of the venous blood from the patient. And it's dependent, volume injected depends on the tolerance of the patient and the onset of radiculopathy. If the patient is not feeling any pain, then you want to put as much blood as possible, because it serves as a tamponade and it closes off the defect. One thing to note is that if we know that somebody has symptoms of SIH or no, intracranial hypotension, not SIH, because now we know that it was injected, you wouldn't want to do an epidural blood patch within the first 48 hours. This is because most of the time the symptoms tend to go down and the dura gets closed off by itself. You encourage bed rest and hydration. So if the person has a lumbar puncture within the first 48 hours, we do not run off to do an epidural blood patch. a CT myelogram of the spine or MRI of the spine can be done. It's helpful to identify the location of the leak and the presence of calcified disc protrusions or osteophytes will be seen on CT. On MRI, a fast saturated T2 is very vital, and it helps in visualizing the accumulation of the CSF in these dural spaces. And you have to be aware of the focal localizing signs, which I'll show you. So this is an MRI T2 FATSAT and an axial image, and this is showing this is the cord, and this thin hypointense signal here is that of the dura. And ventral to that in the epidural space, we see a CSF signal collection ventral to the cord, and we see that on this T2 weighted FATSAT image. On this axial image, we see signal corresponding to the extradural leak of CSF. So this is also an extensive one. We see the dura evidenced by this thin hypointense line here, and in between that you have the CSF collection, right? Almost the entire length of the thoracic cord. This MRI image is also depicting multiple diverticuli of the thoracic spine, which are potential causes for the leak of the CSF. So sometimes you can have hyperintense signal within the posterior soft tissues of C1 and C2, and these are all, they are not due to leakage of CSF into the space. So these are the false localizing signs. So we have to be aware. Sometimes if fast saturating sequences are not well done, you realize that there will be incomplete saturation of the fats at this level. So in patients that have fat leaks, you want to do a CT myelogram, in which a dynamic one, in which you perform the lumbar puncture right on the CT table. You want to have the inclination of the patient such that you just inject and you follow with a CT imaging to track the movements of the contrast. You don't want to do it with a DSM, as in the diagnostic digital subtraction myelogram. Before you move the patients to the CT table, sometimes they will tell you that there's a trauma patient that needs urgent imaging, so your imaging cannot have to hold on. So with the fast leaks, the myelogram is done right on the CT table. So this is an example of how procedure can be done. You have this wedge shape here, which the patients will lie down. This is a prone Trendelenburg position. So the access to the back is secured, and you inject. And once you do that, you're going to follow up with imaging of the spine. So this image axial shows the intrathecal placement of the needle, and just a small amount up to maybe 4 cc of contrast is injected. You don't want to fill the whole column with contrast, just a small amount. And as it tracks down the prone Trendelenburg position, you follow the density of the contrast. Where it is diluted, then you're going to know that that's the site where there is the leak of contrast. So in CSF venous fistula, it's important that the patient is placed in the lateral decubitus position. Okay, so for our initial imaging, maybe just in myelogram may not be positive, but it means that CSF from the intradural space getting into the case. So he shared this one where he did a CT myelogram, and within like 10 minutes of putting in the contrast, imaging shows that there's contrast within the collecting systems of the kidneys, right? So there's no way these intrathecal contrasts can find their way into the collecting system within this short period. Okay, so a diagnosis of venous fistula is highly suspected, and so you have to go back and make sure that you place the patient in a decubitous position to obtain or to be able to visualize the fistula's connection. So this patient has an axial CT, and it shows the double contrast sign, a hyperdense intrathecal contrast, as we can see here, and the extra axial collection is less dense, right? So the coronal image shows the diverticulum, which they suspected to be place where the leakage is coming from. So a digital subtraction myelogram was then done with the patients lying on the side, and it showed leakage of the contrast from that diverticulum. So this is also another case where a CT myelogram was done. Then there are two levels of dixocytophyte complexes seen. Now, the question is, if you see the leakage in that area, which of them is the culprit causing the dural tear? So we see it again, the double contrast sign here with hyperdense contrast in here, and the less dense extradural contrast. So they went ahead to do a digital subtraction myelogram, as we can see here, and is able to track the leakage of the contrast at the C7 T1 level. Okay, so you can use the DSM to be able to pinpoint where the leakage is. So imaging forms like it's more of like complementary. All the methods are complementary. They help in assessing or getting to the root cause of the CSF leaks. They also employ dual energy to make this iodinated contrast more visible. And so we are able to tell where the leaks are coming from. So you just see this CT where the contrast leak is not so pronounced, but on the dual energy, it's so evident that there's a leakage of contrast at this level. So what happens if you have no intermittent leaks? You want to do an MRI with intrathecal gadolinium. This is not FDA approved because of some neurotoxicities, but it stays in the within the neural axis for about up to 96 hours. So it's good for cases where there's slow or intermittent leaks. You'll be able to image the patient even after the first day of the procedure. They can also do nuclear medicine myelography, where they inject the intrathecal 111 indium, diethylene, triamine, pentacetic acid, and you evaluate to see direct and indirect findings. The direct findings include accumulation of the radioactive substance outside the subarachnoid space at where your CSF is leaking. Indirectly, if there's a rapid washout from the CSF space, or you see activity within the kidneys or urinary bladder, or there's poor migration, then it's an indication that there's some CSF leak. So this image shows a CT and the post-gadolinium image, where we see of the contrast leakage within the nerve sleeve on the right in this MRI image. So CT, MRI again. So this the image on CT, and then MRI we see the bilateral leakage of this of the contrast or CSF at this level. So we take a look at the nuclear medicine imaging. So this is the normal control one, where after an hour, it's 2 hours, 5 hours, we don't see any radioactive collection outside the subarachnoid space. Substance along the neural axis. In the patients that is leaking, that's the image on our right, we see that there's early extravasation of the radioactive substance into the paraspinal soft tissues here. So it's extending beyond the confines of the subarachnoid region. Then by 2 hours time, we see that the urinary bladder and the kidneys are starting to show up, and it's more evidence in this 4-hour post-procedure. And by the 24 hours, compared to this one, there's almost near complete evacuation of the radioactive substance over the neural axis. We said that we have to be careful about signal at the upper cervical region. If you have a poor saturation in the fat sat sequence, you the spine, and it would be erroneous to think that you have multiple leaks at all these levels. The leak may be occurring at this level, but because they find itself in the epidural space, they then extend along the dependent portions of the spine and travel at longer along the epidural space of the thecal sac. So if you have a cranial leak, then you will have to do imaging CT or MRI and to be able to localize it. Important differentials, just talk basically about KRE1, because a common feature is the cerebellar tonsillar herniation. Because in the KRE1, if they do an occipital craniectomy, that's going to relieve the patients of the symptoms. But in the patient with SIH, it's not going to change, or is even going to make the condition worse. So you have to look out for other differentials of the pachymeningeal enhancement. If it's nodular, you have to, it means that you're looking at infective or inflammatory or neoplastic causes. Can have just chronic subdural hematomas. Dural sinus thrombosis, this can also even be a feature of SIH, as explained by the dural extensions of the engorged veins. So in order to keep the Morrichelli principle intact, so as these veins get distended, it means there's going to be stasis within these veins, and they can lead to venous thrombosis. So in patients that you see thrombosis, it means that you also have to rule out or look for other features of SIH. So importantly, it's good to note that this KRE1 has a peg-like tonsillar herniation. And in addition to it, you may have abnormalities with the CSF within the cord, and so you may have syringohydromelia. But note that there is no brain sagging, or the third floor is not, the third ventricular floor is not downsloping, okay? As you see on the patients with SIH, look at the third ventricular floor, the chiasm, right? Look for brain sagging. All these will be absent in a patient who has KRE1. So we said that tonsillar herniation is common to both but brain sagging, the reduction in the mammillopontine distance, dripping of the optic chiasm over an enlarged pituitary gland, all these will just occur in only SIH. Okay, so this is not a KIARI1 malformation. In adults where we think that there's acquired KIARI1, you have to be careful, okay, because typically nothing like an acquired KIARI1. Most of the KIARI, it's in the young age, okay, or children. So for an acquired KIARI, you have to make sure that you're ruling out an SIH as the cause. So these are my references, and I want to thank you so much for your attention and having me in the floor for any questions. Thank you so much.